My dear colleagues, friends, ladies and gentlemen, I am indeed grateful to the Indian College of Anesthesiologists for giving me this opportunity to participate in this year of celebration. And my topic for presentation in the next 25 minutes is simulation in cardiothoracic anesthesia and transoesophageal echocardiography. There has been increased use of simulation for medical training, continuing medical education, and crisis resource management in the last few years. The quest for safety and quality has resulted in the development of realistic patient simulators and virtual reality devices, which has enabled the mastery of complex procedures. This is especially true for cardiovascular and vascular anesthesiology, in which need for management of increasingly complex and difficult cases, as well as the performance of variety of procedures and skill sets are necessary for advanced patient management. I have no conflicts of interest, and if there are any company products being shown, it is only for the sake of illustration of a particular method and not for the promotion of the product. I will be dealing with the simulation of pulmonary artery catheter insertion, simulation of management of unstable patients using hemodynamic monitoring, simulation of chest tube insertion, and lastly, I'll be concentrating on the echocardiography simulation. Coming to the first part of the talk, advanced hemodynamic monitoring involves the use of pulmonary artery catheter, which is a radio-opaque catheter 110 centimeters long, which is passed through the right atrium, through the tricuspid valve, into the right ventricle, across the pulmonary valve, into the pulmonary artery. And as it passes through these chambers of the heart, we get the corresponding tracings on the monitor, leading to the final pulmonary artery occlusion pressure measurement, and which is an index of the left atrial pressure, which is used for the knowledge of left-sided filling pressures. There is a development of a simulation app in the iPad, which is meant basically for the learners to know the waveforms and the technique of insertion, which is shown in the next video. This is the catheter being passed through the internal jugular vein, and as you're doing that, there is corresponding waveform shown here. Once it is in the right atrium, right atrial pressure is monitored, and now the latex balloon is inflated and the catheter is advanced. As it is advanced through into the right ventricle, we get a corresponding right ventricular pressure tracing, followed by pulmonary artery pressure tracing, and then the final occlusion pressure position. This can be practiced several times using the iPad app, so that even a novice can insert a pulmonary artery catheter once the sheath is inserted into the internal jugular vein, as he watches the monitor for the development of the waveforms corresponding to the particular chamber the tip of the catheter is in. This is a web-based cardiac hemodynamic simulator where any of the valvular lesions can be simulated. We have the arterial pressure, the ventricular pressure, the right ventricular pulmonary artery pressure, right ventricular pressure, and the left atrial pressure and the right atrial pressure shown in the monitor. This is designed for training and education, and the target audience for this includes medical students, postgraduate students, and fellows in training and cath lab technicians. It provides an environment that allows users to interactively modify cardiac hemodynamic parameters such that the degree of valvular stenosis, regurgitation, and the effect of pressure changes in the intracardiac pressure tracings can be delineated very easily in a situation where we are not exactly doing it on a patient. This is a simulated environment. And we have used the hemodynamic monitor simulator. For example, as is shown here, there is a case scenario with hypotension,
these are the parameters when
which calls for hemodynamic management.
So we got a heart rate of 110 per minute. It's sinusoidal. The pressures on arrival in the ITU was 84/40 with a mean of around 59. PA pressures were around 40/22 with a CVP of.
The mentor is showing the simulated environment
99%.
and ask the audience to interact with him
at this stage
to suggest treatment.
We should do, what should be our next step in management? And the patient is already on 0.08 mics per kg per minute of noradrenaline.
So this is an example of hemodynamic monitoring in unstable patient
and answer
in a simulated environment.
Put your comments in the chat box.
As the trainee suggests the treatment, that particular treatment is given.
There is a question on TEE intraoperatively.
So the particular treatment is provided and the effect of treatment on the hemodynamics is demonstrated on the monitor. Next, coming to the echocardiography, here is a TEE simulator, that is Transoesophageal echocardiography stimulator, that was first commercially available in the early part of this century. The cardinal feature of this system is a realistic model of the heart and great vessels that facilitates easy suspension. And this high fidelity model was developed using a state-of-the-art animation technology, and its use has been made possible by advances in graphics processing units, which can be used in personal computers. Similar equipment is shown here, which can be used for transthoracic or transoesophageal echocardiography and also for bronchoscopic procedures. Let us see this TEE model. The TEE probe is being advanced into the esophagus, and you develop a mid-esophageal 4-chamber view. And by increasing the angle to about 40 degrees, we get the aortic valve short axis view with tricuspid valve. We can interrogate the tricuspid valve and use a pulse wave Doppler to look at the tricuspid inflow velocities in a virtual situation. So this is a very easy method to communicate to the candidate who is trying to learn about the basics of transoesophageal echocardiography. Similarly, the lung ultrasound can be taught in a virtual environment by using simulator. This is the probe placed on the chest to look at the lung parenchyma and also to develop the barcode or seashore sign by use of M-mode echocardiography. And by moving the probe to the lateral chest, we can look at the diaphragmatic contractility and thickening of the diaphragm during inspiration, which is an important component of the assessment of diaphragmatic function. In this model, the operator is simulating a pleural effusion, as is shown in this picture. This is the anechoic area is the pleural effusion, and the ability to add labels and individually highlight the structures may be done virtually in cardiac structures. For example, here we are highlighting the aortic valves, aortic valve and the ascending aorta in the cross section and in the long axis, and in the upper esophageal views, we can see the great vessels. The Blue Phantom training model consists of a life-sized mannequin with an oral cavity and esophageal conduit built-in tissue-like consistency with an anatomically correct non-beating model of the heart. made of composite material suspended in thoracic cavity and accurate surface anatomy from the outside. The main advantage of this simulator is the ability of the trainees to use actual ultrasound system and TE probes for echocardiographic examination. This picture shows the virtual reality 3D heart model with two superimposed scan planes. These are called the targeted cutting planes, which can be used to demonstrate the heart structures virtually in a given window at a given angle when you're using the transoesophageal echocardiography. Similarly, we can develop the models to demonstrate various structures in the heart, be it the great vessel or the transgastric views, mid-esophageal views, or the upper esophageal views. For an echocardiography simulator to achieve its fullest capability, it would need to document the starting point precisely when a trainee is using it and track the changes in position in relation to X, Y, and Z positions, and the angular rotation of the scan plane, as well as the roll, pitch, and yaw of the TE probe would also be needed to be recorded over time. And this can be depicted graphically as the trainee is attempting to move the probe, whether he's making multiple attempts or he's able to achieve the final position with a single attempt can be assessed, and the candidate can be graded and improvements can be suggested if the candidate is taking a lot of time to achieve a certain position or the certain window or certain angle of the TE probe to obtain a certain image. The cardinal feature of this system is a realistic model of the heart and great vessel that facilitates easy insertion. And let us see some problem cases. For example, complications of acute coronary syndrome. This patient, this model, shows a virtual reconstruction of the heart as seen by the echocardiography, transoesophageal echocardiography, 4-chamber views being shown. There is akinesia of the apical, lateral, and septal segments with associated pleural effusion. The same thing is shown in a transgastric view. We have the anterolateral and anterior hypokinesia with the septal walls and the inferior walls contracting reasonably well. And this animation depicts the intraventricular septum in a transgastric view. You can see the intraventricular septum is defective here in a patient who had acute MI, which indicates that the intraventricular septum, there is ventricular septal rupture. The intraventricular septum or free wall rupture occurs in about 1% of patients who develop acute myocardial infarction. It causes 15% of the hospital mortality. This can be easily made out using color Doppler in a transgastric window using transoesophageal echocardiography. Let us take a case of a 65-year-old female diabetic hypertensive with a history of ischemic heart disease, recent history of recent history of percutaneous transluminal mitral commissurotomy on treatment, presented with altered sensorium and weakness of the right side. So this shows the thrombus in transit from the right ventricle to the left side, right atrium to the left side. So this is the reason for the patient to have neurological deficit in the forms of right-sided weakness. And the next case which we are going to show is a pericardial tamponade, where you can virtually see that the heart is swinging in a pool of blood. In patients with hypotension and shock, the cause for shock can be easily depicted if you look at the left ventricular contractility. Is it cardiogenic shock, or if the cardiac function is normal, or patient is hypovolemic, as is shown on the right upper quadrant of the slide, or the left ventricular contractility is poor, or there is right ventricular dysfunction leading to septal shift to the left side during systolic phase as a result of acute increase in the pulmonary artery pressure. This is a simulation session in progress during the International TE workshop at NH in Bangalore, which we conduct annually in the month of August. And we also conduct National Mechanical Ventilation, Hemodynamic and ECMO workshops. And in this workshop, in the year 2017, we devised the indigenous model for the chest tube, where the candidate can feel how to learn and feel how it goes inside the use of chest tube in a case of pneumothorax. This artificial chest or indigenous chest can be prepared using material which is shown here. These were all made for the sake of the workshop, and it was a tremendously successful demonstration of insertion of a chest tube in an indigenous model of the pneumothorax. Before I conclude, I would like to announce the 16th National and 7th International Transoesophageal Workshop and CME, which is being conducted in the month of August. The dates are 24th through 28th. Please join us. There will be some virtual sessions there too, and you would like to, you might see the use of virtual training in this workshop. We'll be using a TEE simulator to communicate the use of transoesophageal echocardiography in real life situations. This is the announcement of the workshop being conducted in association with Indian Association of Cardiothoracic Surgeons, ISCCM, and the International Society for Cardiac Ultrasound. To conclude, a curriculum-based approach including a combination of didactic lectures, online instruction, and hands-on simulation training holds a significant promise in the future. Simultaneous use of multiple modalities can help to provide a uniform, graduated, and coordinated learning experience to a large number of trainees at the same time without endangering the patient's life. You can learn the life-saving skills on a mannequin, on a simulated environment, to be able to become an expert and develop skills and use it for the benefit of patients. At present, echocardiography education relies on top-down approach with set of milestones for achievement for final certification. Adoption of simulation technology in training curricula can enable a bottom-up approach with prerequisites specified for initiation of clinical echocardiography training. Having attained comfort in areas such as basic ultrasound principles, echocardiographic anatomic orientation, and machine homology in a simulated environment, a trainee can acquire more meaningful and wholesome learning experience right from the very first exposure in clinical environment. With this, I would like to thank again the Indian College of Anesthesiology for arranging this excellent webinar, the 100th webinar of the ICA on 15th of June this year, that is today. And thank you very much for joining us. If there are any questions, I would like to, I will be very happy and delighted to take them on and deal with that. Thank you so much.